to today's webinar brought to you by the Orthopaedic Research and Education Foundation India through OrthoTV. Today we have the pleasure of having Dr. Nitin Kimmatkar from Nagpur, and he's going to tell us about some things about the use of the CT scans for trochanteric fractures, and also about how you can use the angle blade plate to fix these fractures to get good stability. But he will also talk about the importance of getting the lesser trochanter, the greater trochanter, and the lateral wall firmly secured in the fixation. So over to you, Nitin.
Thank you, sir. Good evening, all. Happy Holi to all. So these are my thoughts. Malice towards none. And please see to it what is there on this thing. So it is on time.
Share your screen.
Yes, sir. I'm trying. 1 minute.
Green arrow at the bottom of your screen. Ah, that's it. Have you got your preparation? Have you got your talk open?
Yes, sir. 1 minute.
Because you've gone to something else.
So good evening, all. We are talking about CT-based evaluation and surgical rationale for angle blade fixation in intertrochanteric fractures. So let us start with one case. This is one 65 years old female.
I don't think your slides
Excuse
are
me,
on
sir.
yet. Nitin, your slides are not yet on. So maybe you should go back, switch it off, and then switch it on again.
I think it is something paused.
Yeah, so just go off share.
Yeah.
Go to your presentation, put it on, minimize it, and then go to share again.
Is it on now?
It's
Just
coming.
wait, sir.
Yeah.
It's on now, yeah.
Yes.
So this is a case having a 4-part fracture here. Patient was having, this is 65-year-old female with unstable 4-part fracture. This is a AP and lateral view. This is the CT scan of the patient. You can very well see both the hip joints and 3D reconstruction of this CT scan. You can see the greater trochanter is fractured, lesser trochanter is fractured. There is a shaft which is there, and there's an head neck element or head and neck part of the fracture. So this is typical fracture what we get in this age group, and this was fixed with this angle blade plate device along with the CC screw and tying the greater trochanter and lesser trochanter with cerclage wire. So this was progressive healing of the patient at 2 months. This is at 5 months, and this is patient's gait at 5 months. So this is typical of CT scans, whatever we see in these are all 4 female CT scan at various age group. This is 55 years old female. This is 65-year-old female. This is 75-year-old female. And this is 85-year-old female. So unless we see a fracture geometry of these scans and study the scan in details, we are not going to negotiate those fracture fragments. So CT scan is essential in every fracture now in pilon fracture, upper end tibia, tibial plateau fractures, OFA fractures. Why are we not following this CT scan evaluation in intertrochanteric fracture? This is difficult to understand. These are the male CT scans, and here also you can see. different CT scans at different age groups. And so what are the factors which are influencing the fracture treatment in intertrochanteric fracture? First is bone quality. Second is fracture type and fracture geometry. And third is quality of reduction. Fourth is choice of implant. And fifth is placement of implant. These are broad principles of treatment of fracture intertrochanteric fracture femur. So out of which first two are not in our control. We get it from the patient, that is bone quality, age of the patient, osteoporosis, he suffering from the different diseases like hypertension, diabetes. This is not in our control. So whatever bone quality we get, whatever the fracture type and fracture geometry we get, we have to negotiate with that fracture. What we have in our hand is quality of reduction, choice of implant and placement of implant. So this, whenever we are in control of these things, we should be very particular about it. What we should be aiming at is the quality of reduction and how we are placing our implant in what zone. What are we trying to avoid? We are trying to avoid shortening. We are trying to avoid change of an offset. We are trying to avoid non-union, and we are trying to avoid varus. So how do you reduce intertrochanteric fracture? Most of us just see the X-ray, see for the intertrochanteric fracture, and we put it on the fracture table, put it in abduction, adduction, see for the Shyam images in AP as well as lateral. As we have only one implant to put in, that is PFN nail, we don't bother about what reduction we are getting, how to negotiate that factor, how to do a stable reduction. We just aim at putting a nail in that intertrochanteric fracture and get rid of that fracture. What is an accurate stable reduction? Most important in this accurate and stable reduction is bone contact. If you do a good bone contact on anteromedial cortex, it is a load sharing. It decreases the stress on the implant, it decreases the pain, it enhances the fracture healing. And so also it prevents the shortening, and it maintains also proper hip mechanics so as to get good patient mobilization after healing of the fracture. If you study the osteopenic trochanteric fracture, they have a fairly consistent characteristics. They fail simple tension failure in anterior or anteromedial part, and there is varying degree of posterior comminution. So as you have seen this depictable CTs in the previous slides, the posterior comminution is not in our hand. It could be one part, it could be a banana fragment, it could be a 2-3 part, it could be along with associated with a smaller lesser trochanteric part and lateral wall, or it could be a bigger posteromedial part, long spiral oblique fracture and a lateral wall. So all these combinations can be there. So studying of this posterior combination is very important by assessing with the CT scan. What is an important part of an reduction in intertrochanteric fracture? It is an anteromedial cortex. It is an only cortex which is giving you a stable, consistent reduction, and it is only it has failed in tension, so there is a linear fracture line. You should always get a positive reduction on this part if it is in EP, and if it is in lateral, at least neutral or positive reduction on the lateral view. And we generally forget about the posterior combination. So this is very important while we reduce the intertrochanteric fracture, be it be closed or be it be open. So if you are going for an close reduction, at least you should try to put this fragment in an anteromedial positive reduction with various types of measures. Or if you are going for an open reduction also, you should seek for it. Try to over reduce it. This has been emphasized by the James Carr since 2007. But somehow our teaching doesn't go beyond that, and we don't teach our residents that it should be positively reduced. So what happens if it is not positively reduced? This slides depicts you the collapse. If the beak is inside the shaft, then you could get as good as 4.5 mm collapse in that fracture, and progressively the fracture goes into the varus. And if it is in lateral view also, the beak is inside the thing, then there could be a 6 mm, up to 6 mm collapse could be there, and there could be posterior tilting of the head, and it will disturb your reduction. So at most you should do a positive reduction, that is extramedullary reduction, or anatomical or extramedullary reduction in a lateral view, positive reduction in the AP view, and anatomical or extramedullary reduction in the lateral view. That will help you to reduce the collapse. That will help you to retain your reduction, whatever you have attained, and the implant will help for the fracture union. This AO OTA classification has came in 2018. It is now 8 years down the line. And this classification was basically depicted on the AP X-ray. So whatever this is there, like A1.1, A1.2, we are most concerned about A2 fractures and A3 fractures. So this only depicts on the AP view. So some people have tried to classify these fractures on the lateral view also with the help of an CT scan. They have subdivided this trochanteric combination into 1, 2, or 3 parts. This fellow Shiming Chan has developed this classification. But there are more people also who are addressing this fracture with the help of CT scan and with different methodology. This VADA classification is very favorite. It has divided greater trochanter into anterior and posterior part, and the lesser trochanter, then neck shaft and shaft. So accordingly, permutations and combination, he has divided that fracture name, and he has developed this classification called as an VADA classification. Somebody has also developed this CT scan classification. They have put a line from piriformis fossa to the middle of the shaft of femur, and they divided lateral wall into 3 parts, like in rotator, then upper lateral wall and lower lateral wall. So as to see, and they also have measured the lateral wall thickness in the transverse section of an CT scan. So there are many people who have developed this thing. The fellow from India, R.B. Kalian Singh, has developed a column classification. They have developed this femur, upper end of femur into 3 columns, like posteromedial, anteromedial, and lateral column, along with the tuberosity, trochanters, like greater trochanter and lesser trochanter. And permutation and combination will give you different types of fracture. Like 1A is having posteromedial column, which is stable. 1B is posterior column, which is unstable, posteromedial. 2A is 2 columns, either posteromedial plus lateral or anteromedial column, but both are stable. And 2B is posteromedial column, lateral or anteromedial, one of which is unstable. 3A is all 3 columns fractured, out of which 2 are stable, and 3B all 3 columns with 3 are unstable. This another classification is from Chengdu. They define this upper end of femur classification according to the parts of the fracture, like 2-part fracture, 3-part fracture, 4-part fracture, 5-part fracture, or 6-part fracture. They have their own methodology of dividing this fracture, but there is no standardization which one to follow. So somebody from AO or OTA should take an initiative to standardize this classification along with the for the CT scan based classification, so that it could be standardized, and this will help the further research in this fracture. Now this another patient, 4-part IT from femur fracture. This was the CT scan which was done. This shows there is a fracture of a lesser trochanter, then there is a head neck element, there is shaft, and there is a greater trochanter fracture. You can appreciate this thing, which was fixed promptly with the help of a positive reduction with angle blade plate and cerclage wire. But this is the post-op mobilization of the patient. In the ward, he is walking with assisted walking with full weight bearing on that same operated limb. This is 5 days old mobilization, and this is his post fixation CT scan. Which shows that implant is in position, and you can see that this cerclage wire is holding his greater trochanter fragment. Another patient, same 4-part fracture, was analyzed with the help of CT scan. Here he has a long beak of a posteromedial fragment. Okay. This was promptly fixed. With angle blade plate and cerclage wires. And this is this post-op CT scan. This shows that this wire has negotiated all the trochanteric combination and it is very well fixed. And this is his mobilization in the ward, 5th day. Why do we operate this intertrochanteric femur? We need to get this patient out of bed and we need to mobilize them so as to decrease the. But another patient, Jagdish, fixed with an angle blade plate and screws. Another patient with angle blade plate and cerclage wire fixation. So these are different types of patient, whatever we are getting, and we are fixing this. This is one of the comminuted patients having greater severe comminution, and there was an long spiral oblique fragment was there of an head neck element, which was associated with lesser trochanter. It was fixed with cerclage wire, and this is the mobilization of the patient. Very well mobilized, and it is the pain is also less in this patient. So another patient fixed with a same implant, angle blade plate with cerclage wire. Is not progressing. Connection is not as stable. Am I audible?
Yes, sir. Yes, sir.
Yes, yes. My presentation is not moving forward. Just give me the 2 minutes.
Because of more video, sir, it may hang.
Yes, hang. I will stop share and again start. Okay.
Yeah, please, sir.
Just hang.
Recording in progress.
Shall I share from the...
Yes, sir.
Sorry.
He has joined through another. I think, sir, you have taken another computer for this one, sir.
Yeah, you'll have to switch off one because the voice is.
Echo is coming. Please unmute yourself, sir.
I need to share also.
Okay,
Yeah.
so I'll this one, sir.
Yeah.
You
Why?
have to switch this off first. So stop sharing this one.
That is hanged up, sir. Something.
Or just
Okay,
switch
so
it
I'll.
off then. Switch it off then.
I may remove that one.
Yeah.
You are not connecting with this one, sir. So I'll remove.
You can remove
that one. Okay, sir. Okay, sir. Now you can.
So sharing.
अभी शेयर आया नहीं है.
नहीं सर. हाँ अभी आया.
Okay. Yeah, good.
Yeah.
Yeah.
So we'll continue this thing. So this is another patient and was fixed with angle blade plate. You can see how beautifully this wire is holding this Intertrochanteric fragment. They have analyzed all these things with the post-operative CT scan so as to get a good view of what we are doing, how it is been fixed or something like that. So this is the patient. Another patient fixed with this. So let us see the philosophy of cerclage wire. Cerclage wire is very useful adjunct to improve the results. Why we should consider percutary or reduction with cerclage wire with cables also? Because if there is a loss of reduction and shortening are caused by the posterior head rotation due to lack of the posterior support. We now know that there is no posterior hard bone and there is comminution which is unpredictable. So whenever we fix the implant, then it is rotated posteriorly and we get varus. There is a loss of initial bone contact. It will go in varus and shortening, and certainly it will go for failure. So cerclage wire will contain this posterior comminution and improve the bone support. It will contain the bone and it will improve the reduction, and this will help for improving the reduction as well as sustainability of the implant. There are many studies which shows that this posterior middle fragment, if it is large enough, that is more than 50% of an intertrochanteric area, then it gives for a poor results because of the poor fixation of this trochanter. So for immediate reduction as well as post-op stability, cerclage wire was associated with quicker healing and better functional results without incurring the complications. So this is very important. So all should be doing this cerclage wire fixation whenever there is a long spiral oblique fracture, there is a trochanteric combination or greater trochanter which is posteriorly displaced or lesser trochanter which is displaced. And there are fewer complications when the cerclage wire was used in 3-1-A3 fractures. There were lower reoperation rates. There was 3 times more likely to have non-union or fixation, less likely to have non-union or fixation failure, and 13 times more likely to have a good quality reduction. So this is very important whenever we see the CT scan of these patients where there is a long oblique fractures or there is trochanteric combination or lesser trochanteric combination and there is a coronal split of a lateral wall, we should always use cerclage wire for fixation of this fragment so as to improve our reduction and get a good reduction. So cerclage wire was safe, minimally invasive, and minimal effect on blood supply. This has been proved in femoral fractures by Thirachai, and it is very well under our control to use this cerclage wire in intertrochanteric fractures. So another patient, intertrochanteric fracture, was used with the cerclage wire and this angle blade plate and cancellous screws. You can evaluate this with the CT scan. You can see that this trochanter, lesser trochanter is very well got hold with of this trochanteric combination. And posteriorly, whatever the gaps are there, the implant is been contained in the femoral head neck element. So this is very important. Now, what are the problems of proximal femoral nail? This is a one 4-part fracture which was very well fixed with the this PFN nail. This is post of X-ray, and whenever we have analyzed this thing with the help of a CT scan, you can see that whenever we see this nail from in the CT scan, most of this implant is been exposed from the lateral side. There is no hold of an trochanteric this screws, whatever anti-rotation screw or the primary hip screw, whatever we are fixed in this implant, they have very little hold because of the osteoporotic thin lateral wall. So there is, and there is, as such, the other hold of these screws is in the subchondral bone of the femoral head. So this is very having a poor hold, and whenever there is a pain and whenever there is a instability and less fixation of a fracture, patient will not be mobilized properly. He or she will not cooperate to you for walking because of the pain. This is another patient of intertrochanteric fracture with long posteromedial beak and trochanteric combination. Whenever the greater trochanter fracture is there, we always tend to go through this fracture line and produce a wedge effect. And after fixation of this fracture by the nail, you can always see that there is an exposure of an implant on the lateral side whenever there is reanalyzed by the CT scan. You can see there is very poor hold of these screws on the lateral cortex. This is another patient in whom after fixing with the cerclage wire also, the greater trochanter was flying off in the air posteriorly. So this is very important aspect of whatever nailing we are doing. Also the short nails in the large canal femurs have a toggling effect. So this also goes in for an significant loss of reduction and cause varus. So whenever we are using the nail, you should use an adequate size nail in the femoral canal so as to get a coronal as well as sagittal stability in the canal. We don't make the statement that nail should be hammered in, but it should be snugly fitting in the canal so as to decrease the lateral angulation as well as toggling effect. Whenever the short nails are used in the long coronal split fragments, there is also a coronal plane toggling is there. This will also cause loss of reduction and ultimately failure of fixation. What are the problems with nailing? It is an acceptance of a suboptimal reduction when we try to reduce it close. Then there could be a sagittal as well as coronal toggling of implant, and there could be swing motion and secondary loss of reduction. Always in 4-part fracture, we enter the fracture through the wedge effect and cause varus fixation. With lateral wall fracture and osteoporosis, there is suboptimal subchondral purchase in femoral head fixation, so also in the lateral wall. So whenever there is a close reduction and nailing, we only address head fragment, that is head neck fragment and shaft. We just try to reduce these 2 fragments and forget about everything else. The reduction of lesser trochanter and greater trochanter is always neglected and is an issue. Whenever we get an unstable fixation pain, it affects mobilization. This is one patient where this was the IT femur fracture where the patient was fixed with an PFN implant. This screw was very well subchondrally fixed. It was a positive reduction, and still it failed from the posterior aspect and was promptly converted into the bipolar fixation. So this is the usual story, but the patient, we don't get a proper follow-up of our patient also, and we are just missing them. So this is also one patient of an intertrochanteric femur fracture, was fixed promptly with the PFN nail, and there was a severe comminution posteriorly. You can appreciate this thing, and promptly failed from the posterior aspect. This implant gave away and was then further converted into total hip replacement. Now, some concepts about the calcar femorally, a new perspective. What we are now, we have a concept that there is a tension trabeculae and there is a compression trabeculae. And this concept came from the systematic drawings from the Watts diagram, where in London they used to hang a bulb with this compression device and tension device, so as to get a good. This was simulated with the upper end of the femur. Now many people have drawn the anatomical diagrams from the dissections, and they have formed that there are certain types of trabeculae in the upper end of the femur, and these trabeculae are all compression trabeculae. But whatever we are seeing in the extension, that is, patient is standing upright, and we compare this compression force as in this is a primary compression, and this is the tension trabeculae. But these are all compression force trabeculae, because we don't see this patient in flexion as well as extension. Whenever the patient is flexed or in squatting position, there is the other way around. This tension trabeculae takes on the work of a compression trabeculae. So all these trabeculae are basically compression trabeculae, and the confluence of this both the trabeculae at the base of the femoral this intertrochanteric line is a calcar. So whenever we enter this angle plate, we are taking hold of this calcar, this two compression trabeculae, and we are placing our implant in the lower end of the femoral head. So there is a good purchase of bone is there whenever we are putting the angle blade plate. This is an anatomical diagram where you can see that this horizontal trabeculae, vertical trabeculae, and calcar is a good dense bone, and from here we pass on through the calcar to this vertical trabeculae. So we are getting hold of this major chunk of an cortical bone, near cortical bone, into the femoral head. So this is very important while we are fixing in the implant in the femoral head. This is another patient, 4-part fracture with the lesser trochanteric and greater trochanteric combination, very well addressed with the angle blade plate. There was a split in the coronal split in the greater trochanter was fixed with the cortical screw, and this fracture was fixed with the angle blade plate. And this is the post-operative CT scan of that patient. You can see that cerclage wire has taken hold of lesser trochanter, as well as this greater trochanter, which is a banana-shaped trochanter, was been fixed with the help of an cerclage wire as well as a screw. So you should always bear in mind the reduction of the trochanter, lesser trochanter as well as greater trochanter, and get a good reduction as well as good fixation of the implant. So this will give you good mobilization of the patient. So we have put this angle blade plate, which was previously used for non-unions, failed osteosynthesis, but we have started using in this phase fractures. So we have studied around 45 patients which were more than having age of more than 20 years, and we have followed up with functional as well as radiological outcome at 2 months as well as 6 months. We have 39 phase fractures, 4 failed and 1 non-union was there. Side affected was right side, and trauma was low energy trauma in majority of the patients. There were various medical conditions which were associated with this patient: hypertension, anemia, hemiplegia, diabetes, and many of the patients were stable, but around 40% of the patients were unstable, and around 20 to 25% patients were having 3-1-A3 fractures. The hospital stay was minimum of 5 days and mean of 10 days. There were no superficial or deep infection recorded. The fracture healed in 37 cases. There were 4 implant failures, and there were mortality in 4 cases. So at 2 months, there were excellent function was in 5 patients, and which improved over the period of time. At about 6 months, in 25 patients, we could get a good function, excellent function, and in around 10-12 patients, we could get a good function. So final functional outcome with the SF36 score was also improved at 2 months as well as 6 months, like physical health, limitation due to the role limitation due to physical health, emotional health, energy, pain, and social function. Which these parameters all improved at the end of 6 months. The procedure all we know. We'll like to discuss some failure. This is one patient where we had put in angle plate plate. We could get an intercapsular neck femur fracture, which was retorted and was promptly converted to total hip replacement, but still got dislocated and died. Another patient with failed angle blade plate was converted with for refixation with the help of DHS and CC screw with TSP plate. He is good. This patient, another patient with angle blade plate with cerclage wire fixation. There was poor hold in the head, or there could be osteoporosis in it. It got failed posteriorly, and is waiting for total hip replacement. This patient, which has a failed angle blade plate, was converted into total hip replacement. These were a total 4 patients which were having complications or failed fixation. And this another patient, then this is a pre-op CT scan, promptly converted with the reduction and fixed with the cerclage wire as well as angle blade plate with screw fixation. This is one case where failed fixation was converted by the angle blade plate. Would not appreciate this video is not running here. Was fixed with this implant. This is the patient which is walking on this implant. And this is 1 year follow-up of this implant. Patient still walking. These are various cases which we had fixed with angle blade plates, intertrochanteric fractures. These are the walking videos, whatever we have got as we progressed. So this angle blade plate is technically demanding procedure in restoring the anteromedial contact as well as positive reduction, getting a positive reduction because it is in an open reduction. This implant is basically load sharing and tensioning device. It provides an angular stability. The augmentation of a greater trochanter and cerclage wiring of an posteromedial fragment is possible because of an open reduction. We could stabilize all the fracture fragments due to open reduction. With this, early mobilization with minimal lurch was possible. So I think we should always do CT scan of these patients of an intertrochanteric fracture, study the fracture geometry, and then should go in for fixation of this implant or any implant for that matter. But at least you should worry about some reduction should be there in an intertrochanteric fracture.
Thank you very much, Nitin, for a very nice presentation showing the importance of analyzing the fractures on CT scans and also the stability and reduction, emphasizing the importance of good reduction and good stability of the fixation. I think the device you've used is the angle blade plate. I think there are various other devices you can use, but the importance of reduction and the stability of the fracture reduction remains most important in the management of these fractures. So Nitin, one question is, so this positive reduction, so when you reduce the fracture, it could go into positive reduction, it could go into negative reduction, or it could go into anatomical reduction.
Yeah.
So what do you do if you're getting a negative reduction? How do you convert it to a positive reduction?
Sir, in the nailing cases, we put in a Homan retractor in the fracture site, then turn it around 180 degree and get it upside down. So as to take that big from the shaft outside the shaft. So that will help us to get a good reduction.
Yeah, but very often that area is a gap.
Yeah.
So how do you get rid of that gap or do you reduce the traction at that time, or what do you do?
Sir,
make sure that
I think getting it in, there are 2-3 ways. If you if you put a more traction, then fracture sites gets opened up.
Yeah,
Then
that's what I'm
you can-
saying. So
Yeah, then you can push in that dick outside with the help of some Stillman pin or some human clamp, retractor. So, and then reduce the fracture, decrease the traction so that it remains in a positive reduction. So that will help you.
So this is interesting because we call this positive reduction. Long ago with the DHS, people used to talk about the vein county reduction,
Yeah.
which was very similar because you used to get the spike of the calcar and have the shaft opposing it so that you couldn't get collapse.
Collapse. Yeah.
Okay, so it's very similar to what we used to term as the vein county reduction, where you
Yeah.
got a non-anatomical reduction, and that stopped the collapse, and then you could even do a DHS without expecting the fracture to collapse.
Collapse.
So that's interesting concept of how things have gone round in circles and come back to the same position.
So
Any
you have shown,
questions?
yes, sir. So you have shown 1.3 millimeter of positive reduction. So what is the limit, sir? How much how much percentage that can be out?
People have studied various aspects of it. 1.3 mm collapse was there when there is a positive reduction. Whenever the reduction was anatomical or negative, the collapse was more. So what we are aiming is to get a minimum collapse so that patient's gait is not affected. So that is the importance of getting a positive reduction. If we get a collapse or if the neck shaft angle is decreased or varus is there, patient will always lurch. So to decrease this lurch, we are aiming at this positive reduction to get a minimum collapse.
Yeah, so you can get a negative reduction and yet not have a varus.
Yeah,
Okay, so but it will still allow a certain amount of collapse to occur, and that is the advantage of the positive reduction. It is because the lateral fragment gets buttressed to this beak and then can't collapse any further, so you don't get medialization.
So that is our understanding that collapse is only unidirectional. This is not always that way. Because whenever there is a 2 or 3 mm collapse, the patient head can get antiverted as well as retroverted.
True.
And most possibly it is retroversion. So it will magnify your effect of collapse. And you will certainly reduce, the reduction will be lost and your implant will fail. That is for sure. So this, why we don't get follow-up of this patient? Because they generally go in there and 50% of your patient die within 1 year. So because they are painful, they are not walking, so there is a high incidence of pulmonary embolism, then they could not come to the hospitals.
Yeah.
You have got one chance to reduce this fracture, stable reduction.
Okay, great.
So,
Any further questions from any of the delegates or participants?
not yet, sir. Well, we are waiting for the question, sir. You have more thing who you have explained in your lecture about the posterior combination, which is one of the reason of the failure of these implants. So how you can tackle it, sir? Although you have explained few things, but and I just want to mention that because Sagase sir is in the group, so if sir will get involved in the discussion, that will be great. Welcome, sir.
Hi, sorry, I came late, so I will not be able to participate in questions. But then
It's about angle blade plate, sir, and about angle
yes, I
blade
know.
plate
I mean,
used in yes.
so I just had one query that there was a large proportion of fresh fractures.
Yeah.
So how do you decide whether to do a nail or an angle blade plate? Maybe this is already discussed. So
No, it actually hasn't been.
We are using angle blade plate as a primary implant. We are not, we are
correct.
one thesis on this thing, and we are focusing on open reduction, get a positive reduction, and get a hold of tuberous this is greater trochanter and lesser trochanter with cerclage wire, and get a good hold with the angle blade plate.
So Vikash,
so that is what I wanted to know is to when do you decide in a fresh fracture to do a angle blade plate or a PFN, femoral nail,
so
or number one, and number two, if you have a good anatomical reduction, would you still go ahead and change it to positive reduction?
No, so Vikash, I think you got something slightly mixed up because this is his primary way of fixing these fractures.
Okay. Fine.
So whether you agree with it or not, that's a different issue altogether.
Correct.
But this is his
So I
primary way.
thought,
So yeah.
fine.
So it's like someone
Fine,
uses
absolutely
DHS for all the which used to be true some years ago, but today we
Correct.
use them depending on what we find in the particular fracture.
Perfect.
I think what is important is the emphasis on reduction and stability. That remains whatever implant you use.
Correct.
Agash sir, one point is there. Whenever there is a 4-part fracture and we reduce that fracture over the fracture table, whatever we are fixing with the nail is only shaft fragment with the head neck element. We are not addressing lesser trochanter as well as greater trochanter condition. So it is by mere 50% chances there that you might lose some reduction or something. Why cement came with the TFNA? Because to get a better anchorage of the head so that your implant should not displace. So that was the idea of cement.
No,
So
but you can wire the trochanter, etc., just as with the nail, as you can do with the DHS or DF angle blade plate. So I think that is the more important part of it, is that you must get your reduction properly so that you get the implant becomes a load sharing implant rather than just bearing all the load of the fracture. That is irrespective of what you use, because even with a nail, if you don't have a reduction, the implant becomes load bearing. Yeah?
Correct. So even if you have a good anatomical reduction, will you change it to positive reduction?
there is one study, sir. The anatomical reduction will give you about 2 to 3 mm of collapse. Positive reduction will give you about 1.5 mm collapse. So there is certain differences there. If you want to err on this side, we should err on the positive reduction.
No, but what he's saying is very relevant, because if we get an anatomical reduction, we would not change that. We won't convert that to a positive reduction.
Depends.
Okay, we won't deliberately open it and then try to get a positive reduction. If you get an anatomical reduction, okay, that 2 millimeters of collapse really doesn't matter so much, because that is these fractures heal by a little bit of collapse.
Yeah.
Okay. So yes, but if you're getting a negative reduction, you would definitely try to convert it to a positive reduction. And you would rather take a positive reduction than a negative reduction or even an anatomical reduction. Okay, so
I would like to mention that this is an art. Using an angle blade plate is a great art which every surgeon should master. I think this is something very important.
So I think at one time when we learned our orthopedic surgery, this was part of our dealing with these subtrochanteric fractures, distal femur fractures. We use the angle blade plate as a routine.
Right.
However, today very few people get to use this, and this implant is not readily available everywhere. So that becomes an issue.
Correct.
So just one basic question, sir. That what is the entry point of that angle blade plate, and what are the precaution while you are using the cerclage in the LT, laser trochanter?
As it is an open reduction, we generally wire the trochanter as well as lesser trochanter initially itself so as to get a good reduction. When you get a good reduction, then entry is a very not very important issue, because you get a whole trochanter constructed in front of you, and you can just put in just a guide wire with the Shyam guidance so that it enters in the lower part of the femoral head.
So I think, Janki, you should read the first and second manuals of the AO. Huh? They will give you exactly how you use the angle blade plate. They have specific guides which allow you to put it at the right angle. You have to get the correct rotation, because even 5 degrees of rotation will end up your plate being either anterior or posterior. Okay, so this is important in the angle blade plate, that you get the exact positioning of the blade and the plate right. Okay, but these are very well given in the manuals if you look at the original AO manuals.
great implant, but a very unforgiving implant.
Exactly. It's not an easy implant to use. And if you saw the failures that Nitin had, if you look back and you saw that the exact position of these implants were not right. Okay.
Correct.
So the implant, if you get it right, is very rarely fails. But it's not always easy to get it right.
Right. And sir, these were done by the 5-6 surgeons, so everybody
Exactly.
has
So
a knack of doing this.
I'm not saying you, but I'm showing the cases you showed which failed. If you saw the blade was either too anterior or very close or a bit superior where it had a chance of coming out. Okay. Thank you very much. I think we should call it a day now. Good to see you, Vikash, as usual. And
Thank you.
Bye,
Nice talk. Thank you.
Thanks a lot. Yeah.
Nitin, thanks a lot.
Thank you, sir.
Thank you very much. Okay. Bye.
Janki. Bye, John.
See you. Bye.
Bye, Nitin.
Bye, sir. Thank you.
Please.